that flow and take a picture of it, and that's what you get right here. You can make flow going towards the transducer one color, and flow going away from the transducer another color, and look at the arteries and veins wherever. So when you are suspecting, you get that patient presenting with a painful calf that when I woke up this morning, it's noticeably bigger than this side over here. Hurts like crazy. Hurts to walk on it. And you send them for a Doppler ultrasound. You don't send them for a regular ultrasound. You don't send them for a CT. You send them for a Doppler ultrasound, and that will detect flow in the vessels. And they actually will, what they do is, if this is the vessel here, they put the transducer on it, and not only measure the flow, they press down. They want to be able to impede the flow by putting pressure on it, all right? And they will report that to you. If it's compressible, that means there's good blood flow. There's no DVT. So vessel compression and the Doppler flow studies, that's how you use this modality. Now over here you see gallstones sitting in the gall bag right there. And over here there's a young'un. Young'un to be. Radionuclide imaging means what they do is they take something and they make it radioactive, make it an isotope. They tag something with an isotope. If you're interested in the thyroid, you want to take an iodine molecule, which is exclusively taken up by the thyroid, and tag it with a radioactive marker. You can inject that into the vein, and it will concentrate wherever it happens to go, or where it happens to concentrate. And you can look for the outline of the structure once you put them under a Geiger counter. This is radioactive material. It does have, it is ionizing radiation. The isotopes, though, are very short-lived, from just a few hours to a few days. But they want to make sure, if I'm doing a radioisotope study on your thyroid, they want to make sure that you don't be around little babies, that you're not going to be holding a little baby up to your neck for the next 3 days. Because your thyroid is radioactive until the isotope decays. These things used to be a lot more popular than they are now because we have different options now. There are a couple of them that are frequently used. This one on the left here is a thallium scan. And what it does is the isotope is picked up by the heart. So the ordinary density of the isotope is here. You're seeing the ventricle wall in that bottom panel. Then you get them to exercise, like a stress test, and because the heart, because of the coronary artery disease, or because of its post-MI, the heart muscle is not taking up the isotope as it should be. It should be taking up more of it. Instead, what you see is it taking up less of it. And in this particular image, there's a defect, meaning there's no blood flow to that area. That's scar tissue, probably from a previous MI. So a technetium scan, a thallium scan of the heart is something you want to do if you suspect wall motion abnormalities. Now on this side over here is a bone scan. They inject here material that's picked up by metabolically active cells. And the more metabolically active cells, like a cancer, is going to take up the stuff more readily. So you're in a Geiger counter here, and it just gives you this silhouette. It doesn't give you any specific, wonderful image, but it is telling you three things. One is the radioactive substance is filtered through the kidneys. It's concentrated in the bladder here, and it's concentrated all down here in this guy's knees and legs. So that's where the metastasis would be down in here. So this is a bone scan. This is not a PET scan. There's a thing now that is more common. A cancer diagnosis usually is always followed by a PET scan, positron emission tomography, that relies on technique more related to MRI than it does radiology. But it's the same type of thing. It detects hot spots of malignancy. If your PET scan is negative, that's good. If it's positive, then that means you have metastasis. And that's about all I'm going to say about that. Anything else from you guys?
I have a question. So on
Tiana, what is your question?
on MRIs, a lot of times we have trauma patients that are in our unit for a long time, and they have their C collar on, but we can't clear it because they're not coherent. So a lot of times we'll do CT, see if there's a fracture, and then if not, eventually we'll end up taking them to MRI to see if there's any tissue damage. Is that where we do that?
MRI in terms of looking for a cervical fracture?
I'm not really sure, so they can get their C collar off.
Well, that's going to tell you, be the most precise when it comes to the ligamentous structure of the cervical region.
Okay.
Basically, you know, outside of a trauma center where you don't have ready access to CTs or MRIs, if you shoot a cross-table plain film and you see all 7 vertebrae and there's no pain in palpation of the posterior neck, then you can take the C collar off. That's the most, that is the tightest your butt sphincter will ever be, is when you are the one responsible for taking that C collar off. You're the one that gives the order to take that C collar off. Your butt sphincter will never be tighter at that point. Because they'll either be okay, or they'll be a paraplegic or quadriplegic. So, I just, I hated that. You'll often hear the CAT scanner referred to as the tube of death, because people rely on imaging much more than probably they should. With every trauma victim, they get a CAT scan of everything. So if you have an unstable person and you send them off for a CAT scan, they'll usually arrest somewhere between here and there and back. How many times does that happen?
Multiple times.
Multiple times. That's why it's called the tube of death.
We're on the bed doing CPR as we're going back to the room.
That's right. They get in the CAT scanner, all of a sudden they go into cardiac arrest, and you're doing CPR on the way back. You need them to be stable before you send them off to a scanner. What other questions do you have? Okay. Hope you all did well.
Y'all, yeah.
Okay.